just that if you're online and you have a question, pop it into the chat. That works really well. And welcome to everybody. We're really excited to be here. There's so much positive going, so much work. It's exhausting, but when you look at it in aggregate, it's totally inspiring. So we're really happy. And we'll start with the obvious news of Jimmy Buffett. I think everybody has heard and thought a lot about that recently. He did pass away of Merkel cell carcinoma about a week ago, and this was on ABC, CBS, NBC, CNN, New York Times, et cetera, et cetera, et cetera. And so well known as in Margaritaville and creating all of this world of that. But just as a metric of what the education and impact was of his noting at the time that he passed that he had died of Merkel cell carcinoma, we normally get every day 300 unique visitors to our merkelcell.org website. And that went up to 90,000 in one day, unique visitors to our website. And it has, it tailed off here, but that is literally more than 1 year of traffic in one day. So we hope that some of that education and information will continue on, and clearly tells us that no matter what you have in the way of superb care and resources, we can't fix this disease for everybody. So tonight is sort of about that and how we're getting to the next level. So here are those topics of what we're going to tackle tonight. I am the herder of cats, and we'll give a short overview. And then Kelsey is going to talk about how we get information out to our extended team, newsletter and the website that she is in charge of. Then we'll have a short interlude of our first of 3 patient stories talking about their experience. And then Dr. Lisa Zeba has joined us from Stanford for a couple days in the clinic and to give a talk. She is leading the national effort to characterize what we think will be the newest, best blood test for tracking this cancer. And it'll work probably in conjunction with the antibody test, but in some ways, like the fact that it should work for essentially 100% of patients instead of 50%, it is clearly better. Then Samia Jani is an extremely talented MD PhD student who will tell us in a James Bondian fashion what it exactly means for a cancer-specific T cell to kill a cancer cell, and why that happens in some people and why it does not happen in others. That is the multi-billion-dollar question that all of immuno-oncology is trying to answer. And Merkel and our extended team here has a very important, exciting new chapter in that realm to share with you tonight. And then Austin Jabbour and Ariel Finberg will end up with talking about some of the trials that we're most excited about, that were kind of homegrown here, as well as a smattering of the other trials that are relevant for Merkel around the country. So here's thanks to our team and event organizers. These are some of the dozens of people that have made a lot of effort to put tonight's event together. Thank you so much from our lab and well beyond. One slide of orientation on Merkel cell carcinoma, definitely more on our website. About 3,000 new people per year in the United States will get this cancer. Almost 1 in 2 of them, almost 1 in 2 of them will have it come back, which is a huge number compared to any other skin cancer. Risk factors, I think you all know. Age goes up enormously over 50, 60, 70, the risk of this cancer in particular, sun exposure, fair skin, and immune suppression. 2 major causes: this virus that's on our normal skin from the time we're young children through every day, and crazily, 1 in 3,000 people over their lifetime will get this cancer driven by this virus. So some very rare things have to happen in order for that to happen, for the virus to actually cause the cancer. And then about 1 in 5 people caused only by sunlight will get this cancer. Treatment is usually cut it out with surgery, radiate it at least a little bit, and that will fix a lot of people, many times for good in terms of this cancer. But if the cancer comes back and spreads elsewhere, then we now have 3 FDA-approved drugs. Bavencio was first in 2017, Keytruda second 2018, and Zinniz was just this past year. Less than 50% will persistently benefit, though. That's a tenfold improvement, as I'll mention in a moment, but we have work to go. So that's huge progress, more work to be done. Let me show you what that looks like in terms of advanced Merkel cell carcinoma. This is what you can't just cut out with a knife or radiate. This is where we were before 2017. 5% of people were in green, long-term benefit with chemotherapy. All of this yellow plus the green, 60, 70% of people had a lovely shrinking of their tumor, but on average, it lasted 90 days from the first dose of chemotherapy. And then the immune system was suppressed from the chemotherapy and the cancer would come back with a vengeance. So starting after 2017 and the availability of these drugs, that's a tenfold increase in that green chunk from 5 to 50%. And we still have people who never benefit and who benefit transiently. But what we hope to do is increase that green up again another chunk to about 75% of people who are benefiting for years at least. Maybe not permanent, maybe not 100% gone, but living for years at least. And we have plans to get there, which we're going to tell you about a little bit tonight. So a couple recent highlights: Thomas Pulliam and Samia Jani are 2 spectacularly talented and very hardworking MD PhD students who have asked questions about these guys, the killer T cells that can target and kill Merkel cell carcinoma. And they found something that Samia is going to tell you about in more detail. But if you don't have Merkel cancer specific T cells in your blood, you very likely will not respond to our best immunotherapies. And you're asking, is that a surprise? You need something that's going to be activated and targeted to kill the cancer. It's been so hard to get at that. And we'll tell you a little bit tonight about why that was hard and why this has implications for other cancers and for this cancer. We have an ATR inhibitor trial that's going to open this fall in 18 clinical sites in the US and Canada. And Ariel and Austin are going to be telling you about several trials, including this one tonight. And then our monster grant, our PO1, was recently submitted a few months ago, 804 pages, $15 million as a request to the National Cancer Institute. And it's going to be reviewed in about 2 weeks, and we'll get a score soon after that. And these are very, very hard to get, sort of 80, 90% failure rate. But we think that we did really well in the last period, over 50 publications, thousands of citations, lots of changes in management, and new insights into the disease. So we're crossing fingers that they will like what they see. So we want to thank our donors. Since 2006, we've received over 5,000 donations, on average about $75 each, totaling over $13 million, which is just incredibly transformative in terms of what we've been able to do. This has allowed us to generate the data for and move forward on our first vaccine trial to prevent Merkel recurrence, and will help us run this ATR trial that's going to try to help patients who don't respond to our current immunotherapies. It, in an ongoing way, helps us keep that Merkel cell website updated and informative, and support and training for many lab members. And here's this image that we show each year because it's so striking. You know, I'm supported more than half by philanthropy, and some people are supported 100%. Our clinical fellows here, I've got this highlighted, Ariel and Austin, who are speaking tonight, are 100% supported by patient donations in order to spend time on the phone with people, help get their data, help connect them, get their docs to join our Thursday call where we talk about tricky patients and we can talk about them. And you can see the amount of green across our undergrads, our graduate students, our postdoctoral research fellows, and our research staff and faculty. And it's really impactful. So along those lines, thanking Christine Chan and Sherry Dotson, our main philanthropy partners. Last year, UW-Medicine and Fred Hutch consolidated fundraising at the Fred Hutch Cancer Center, and the SCCA kind of technically went away. It's just on paper, and it's much more efficient now. It's much better. The whole thing is a big improvement, and there's less confusion and such. And if you want to make a donation, this is the information. And yes, for the high-tech people, the QR codes are right there, and you can just click on that, and it takes you to that page. And if you say you want to support Merkel research, it will come to our team. And that's it for me. I want to now bring up Kelsey Cahill, who is our wonderful research coordinator and just finished her advanced nursing, is in the process still of advanced nursing training. And she's going to tell us about the newsletter and the website and our efforts to keep everybody updated. Okay, Kelsey.
Thank you, Dr. Neum. Hello, everyone. My name is Kelsey. I'm a research coordinator here at the lab. I'd like to take a few minutes to tell you all a little bit about our website, merkelcell.org. It has come a very long way since it was first launched almost 2 decades ago. You can see this photo here on the left. This is what it looked like when it was first launched in 2004. This was an effort by Dr. Neum and one other person just to get the information out there and available as a resource to patients and providers. And so this is how it looked for a while. And then over a decade later in 2016, it got its first major revision and to look the way that it looks today. And now we've got upwards of 80,000 unique visitors every year. And so our next major accomplishment came in 2021 when we launched our newsletter, which now has over 500 subscribers. So now I'd like to tell you a little bit about the resources that you can find on merkelcell.org. So first, we've got the recurrence risk calculator. So this allows patients just to plug in their own personal information and get a percentage chance that their cancer will come back at the time that they were diagnosed, and then any length of time afterwards, because that risk starts to go down as time goes on. So 2, 3, 4 years later, they want to see where they're at. You can go to the calculator, plug your stuff in, and you can see. And we use that in clinic too with our patients. So it's a very useful tool on the website. We've also got a list of MCC providers. So these are providers who have experience with Merkel cell carcinoma patients and who agree to provide care with a multidisciplinary team. It's got physicians from all over the country and also from different countries as well. It's not always possible for patients to travel to other states, and so it's really important that they be able to find something that's close to them with a physician who has some experience with Merkel cell carcinoma. We also have this news and publications page, which has up-to-date research on Merkel cell carcinoma and their treatments. There's a group of us that meets every month to read over this research. It can be really tricky to understand, and we want to make sure that patients can understand what this research is saying. And so we try to summarize it in a way that is accessible to anyone, even if you don't have a science background. And so these publications are what is included in our monthly newsletter. So we also have extensive information on MCC management, from testing, diagnosis, treatment, prognosis, and then just resources for patients and physicians. And so if you aren't subscribed to the newsletter, this QR code you can scan and it will take you to a sign up page. You can put in your email. And that's the monthly newsletter that has those summaries that we generate about the most up-to-date research. And so next, we have a patient story, Mr. J.D. Walsh.
Hi, my name is J.D. Walsh. I live in Los Angeles, California. I'm an actor, and I got diagnosed with Merkel in January of 2023. Earlier in December, I had noticed a growth on my thigh, and I decided to get it checked out. And that started a series of coin flips where I just kept missing the coin flip. You know, we did the ultrasound, then we did the MRI, and then we did a surgery to remove it with a biopsy, and then the doctor gave me the the news. When I first got diagnosed, I was devastated. It's interesting. I think people in the room right now know and relate, but until you've gone through it, until you've really stared into the abyss that your life is going to end much sooner than you thought it was going to, I don't know if you can actually appreciate it. It's you just start looking at everything that is great in your life and thinking, oh, I'm going to lose all of this. I'm going to lose my kids. I'm going to lose my wife and my house and my career and my friends. And nothing can bring you joy, because everything that brings you joy makes you sad because you're going to lose it. When you put in Merkel Cell into YouTube, a lot of what you read online is from 10 years ago, where I think they were like using leeches and such to cure this thing. But no, now they are, I think this immunotherapy is a game changer, and I hope that people know about it, because when that first week, I didn't know about it. And that was very, very scary. There were two people in my life, one who had gotten a brain tumor, and another woman who had had breast cancer 10 years ago, and then it came back about a year ago. And they were good friends. And so I reached out to them. And I think that that's really important. I can be vulnerable with my wife, but it was really nice to have two friends that I could just cry with and be angry with about this and what it's like, and how nobody knows who hasn't gone through this, what it's like. That concept of F cancer was something that I saw on bumper stickers, but until you've lived it, you don't really get how much passion there is behind that concept of F cancer. And now I do. It's a little weird to be in one of these videos, because when I watch these videos, and I've watched many of these videos, they're always survivors. And they're always like, oh, that was in the past. Oh, that was crazy when I went through that. And they're 3-5 years out. And I'm 7-8 months. And so I'm still in the foxhole thinking, I don't know if I'm getting out of this. So that fear is pretty overwhelming. Side note, as you go through this journey, get to know those receptionists. Drop off some cookies, because they hold a lot of power of when you're going to have meetings and appointments. So make them your best friend. I think the most important thing is that people have hope. That's what surprised me. I felt so depressed at the beginning. I did not feel like I was going to survive this, and I still might not. But at least I have hope, and I feel very happy that I'm doing everything that I can to survive this. So that's a good feeling.
So Dr. Lisa Zeba, our good friend from Stanford, we're on the call with her every Thursday to do research and take care of patients. She's going to tell us about the exciting new developments in blood tests. Dr. Zeba.
Thank you, Dr. Neum, and thank you so much for inviting me to the Merkel CELLebration today. It's really an honor to be with you and with all of your patients here today. As Dr. Neum suggested, I'm going to be talking to you about the blood surveillance test today. And many of you have actually had some of these tests, the AMERC and now the new circulating tumor DNA test. So the first question that we always ask whenever we're doing any type of research is why? Why are we doing this? Well, Merkel cell carcinoma, as you know, has an extremely high recurrence rate of around 40%. This is compared with melanoma, another common skin cancer, which is around 7%. Also, Merkel cell carcinoma grows very quickly. So why do we want to detect this early? Well, we want more shots on goal, to use a common euphemism. In other words, if we treat you for your Merkel cell carcinoma with our first agent, for example, an immunotherapy, if that doesn't work, we want the time to be able to choose a second agent before the Merkel cell carcinoma gets out of control. Therefore, we want to be able to detect that you're having a recurrence very early. So just to go over kind of the technological advances that we have used over the years with Merkel cell, back in the dark ages when, as J.D. Walsh suggested, when there were leeches, we also had the hand full skin check exam and feeling your lymph nodes and using our eyes. Subsequently, of course, the CT scan was developed as well as the PET CT scan. And then in 2011, Dr. Niam's group developed the AMERC test. This is a serology test that can detect positive, polyomavirus positive Merkel cell carcinoma. But that leaves out the polyomavirus negative patients. And so there was a possibility here for us to have a technological advance. And in 2021, we started working on this circulating tumor DNA test. And this allows us to detect both polyomavirus positive as well as polyomavirus negative cancers. So just to briefly review the AMERC, and as many of you may know, this is a serology test. And what that means is it's detecting the antibodies that you're creating to the Merkel cell polyomavirus. What happens is when your antibodies rise, that is an indication that you are probably having a recurrence. And as I've already alluded to, what are the disadvantages here? We can only use it in about half of patients that have these antibodies to Merkel cell polyomavirus. The other disadvantage is that once you've already had a recurrence, your antibody levels tend to remain high, and therefore it's difficult for us to detect multiple recurrences. So we had some technological things that we needed to overcome, which meant that we decided to help create this circulating tumor DNA test. So what is circulating tumor DNA? This is sort of an interesting concept. This is a sort of picture of the Merkel cell carcinoma, and it's supposed to be, it's not a very good picture, but it's supposed to be shedding fragments of DNA into the blood. What do we do? How do we detect that? We are able to sequence and look at the genome of your original Merkel cell cancer, and we're able to pick out your own personalized mutations that make your cancer your cancer. And then we build a test that is able to detect those specific mutations. We draw your blood, we check for those mutations, et voila, personalized circulating tumor DNA test that's highly sensitive for detecting Merkel cell cancer. So how do we use this in clinical practice? This is just a schema. This is not a real example, but essentially you come in, you have the Merkel cell on your body, we draw the blood, and voila, you have a positive circulating tumor DNA test. This is represented over here in this red dot. You then get treated with your initial treatment, and bam, it goes down to 0, as we expect. It stays 0 for a time. This is called your surveillance phase, where we're checking you every 3 months to figure out if you're having a recurrence. And then unfortunately, it goes up, and that indicates to us that you might be having a recurrence. We do a PET scan, and we note that there's something that lights up. Yes, you're having a recurrence. We know that we need to treat you, like let's say with immunotherapy or with surgery or with radiation. It goes back down to 0, and that indicates to us that our treatment has been effective. So this is how circulating tumor DNA works in practice. Some of you may have been actually a part of our trial, our observational trial, looking at testing circulating tumor DNA in order to figure out the whistles and the bells, figure out what the advantages and the disadvantages were of this test. We enrolled 319 patients across 6 different academic centers across the country. Obviously, University of Washington was one of the big sites. And then, of course, at Stanford, we did this as well, UCSF, Northwestern, Dana-Farber, and Moffitt. And this is sort of an update on, we presented this a little bit last year, but this is sort of an update on what we discovered with these 319 patients. So the first thing is that circulating tumor DNA level is in fact correlated with the size of the tumor that is present in the body. And that is represented by this sort of linear line here. The other thing that's really important is that this is us sort of denoting size. This is the size of a pea, which is around 1 centimeter. And we can actually detect Merkel cell carcinoma that is less than 1 centimeter in size using this circulating tumor DNA test. Why is that important? Well, that is actually the limitation in size of a scan. So we can draw your blood and determine if you're having a recurrence much more quickly than if we just did scans. The other thing of note that came out of this study, there's sort of the two main points of the study, is that when you are in surveillance, what happens if you have a negative test? What happens if you have a positive test? So if we expect that you don't have any Merkel cell carcinoma, you're in surveillance, you have a negative test, this gives us a 3-month window into the future. During that 3 months, there is less than a 2% chance that we will be identifying a Merkel cell carcinoma recurrence in you. This allows us to have good confidence, even in the setting of not doing scans, that you are negative for disease. However, a positive test during this time gives us around an 80% chance that within 1 year, you might have a recurrence of your Merkel cell cancer. So I'm sort of wrapping up here. What are our sort of take-home points from this talk and from circulating tumor DNA as well as AMERC? Early detection is key. Circulating tumor DNA works in about 95 or actually greater than 95% of patients. There are some exceptions when we do a needle biopsy and we don't have enough material to make the test. Those are the main failures that we have of circulating tumor DNA. The other take-home point is that both AMERC and ctDNA are very sensitive and useful for surveillance. They can both detect a very early recurrence. Circulating tumor DNA in particular can help us avoid scans because we have a very good confidence that a negative test means that you don't currently have disease that is detectable by a scan. And then in the future, very interestingly, we may be able to predict which patients, after we treat them and we expect that they don't have any disease, we may be able to predict which patients need additional treatment, more so than we've already given them. If they have a positive test, that likely means that there's still a little bit of disease left and we might need to give them a little bit more treatment. So that summarizes the circulating tumor DNA discussion. And now we will take, I hear, one question from either the audience in person or online. Yes, yes. The question is, how many patients in the ctDNA study were antibody positive and how many were antibody negative? It was a reflection of approximately, it was about 60-40. There was 65-35. It was approximate to what the natural prevalence is of antibody positive and negative in the community. Yes, go ahead.
Of the 355 in the study, how many showed recurrence?
That's a good question. Excuse me. The question is, how many patients showed a recurrence and how many were we able to pick up? There were approximately, I believe, 70 patients who had a recurrence during the study. There were 2 patients that we could not pick up the recurrence. Excuse me, there were 4 patients. 2 were actually errors. As it turned out, 1 patient, the test was made to a different Merkel cell. It was a different primary. This is such a specific test that it will not pick up a second Merkel that is not your original. The 2 patients for whom it did not work for truly were patients that had very small dermal metastases, less than 1 centimeter. And so that is also why we value the physical exam in combination with these ctDNA tests, because as it turns out, for whatever reason, teeny grain-sized recurrences are not picked up. They would have been at what they were in the future after the original, but they were initially picked up on physical exam. Are we allowed to answer more questions? Okay, one more question.
Why do you need to sequence the tumor rather than just using a panel to detect frequent mutations, 53 or the PID kinase, et cetera, et cetera?
That's a good question. So they've tried, oh, excuse me, I apologize. The question is, why don't we just sequence the common mutations that are in Merkel? There are 3 common mutations, P53RB, et cetera. This has been tried. They use 16 separate mutations to build this test. And it's likely that 3 are not enough. And so that's my best answer for this. There's Natera, the company that does this, has one of their IP is to basically be able to figure out which mutations are going to be stable over time throughout the life of the tumor. And they pick out 16. Sometimes the polyomavirus positive patients do not have all 16. Sometimes patients have fewer than 16 mutations, and yet we are still able to, the sensitivity and specificity, this is a technical term, but the quality of the test is actually identical regardless.
Thank you. And we'll go to patient story number 2.
I'm Sue from Oregon. Started out as a small cyst in my left wrist, which kept growing. Later, that cyst came to the surface. About in August, my dermatologist biopsied, and the results came back as Merkel cell carcinoma. I was kind of shocked. I did not expect cancer, other than it getting large enough to the point where I needed to move my watch from my left hand to my right hand, and getting where it was more difficult to bend my wrist. Everything felt okay. After he told me of the Merkel cell carcinoma, he called daily until I found Seattle Cancer Care Alliance. 2 weeks later, I was in Dr. Niem's office, where a flurry of activity took place. At that time, the Merkel cell was shown to be a stage 3B Merkel cell carcinoma. And at that time, that was almost a 50% reoccurrence risk. I went through all the testing, and the medical plan at that time was for the radiation. The radiation was set for 3 treatments, and it had spread to lymph nodes, and I had 3 lymph nodes removed at that time. The radiation was very helpful to me in that I did not have to undergo any surgery. And while I didn't know what to expect, I think that was the best treatment for me. The biggest surprise I had was that with the radiation, while the skin seemed very thin and fragile, I was told that the radiation, the skin would come back to normal and would not slough off. My biggest surprise was it did not slough off, and it returned to normal skin. I was amazed at that. I was also amazed that my risk went from just under 50% reoccurrence to now 10% reoccurrence. And I'm just amazed that the care I got afforded me my life. Part of it included a circulating Merkel DNA test. The circulating DNA turned out to be important. That's a follow-up way to monitor. And my new favorite number is 0. The biggest obstacle was being able to see my watch on the other hand. I make light of this, as in that's just me. As far as the obstacle goes, it was just getting diagnosed initially. Once the diagnosis was there, trying to find a place that treated Merkel cell carcinoma, I guess, was the biggest issue. But about 2 weeks after my initial diagnosis with my dermatologist, I was able to obtain an appointment with Dr. Niem's office, in which my husband and I traveled to Seattle. And in this, I felt comfortable in going to the office. It seemed like a flurry of activity and overwhelming. And at the same time, I now know that should I ever have Merkel again or any other cancer, Seattle is going to be my first choice. I tend to be a very private person when it comes to medical. Basically, the strength I had was with my husband, who was there during the treatments, and I guess with the dogs I have. I was able to talk with my spouse and enjoy the dogs and walk when possible. That was in between the flurry of activities Seattle had for me. Anyone new to Merkel cell carcinoma, first take a breath, relax, and get yourself to an experienced medical facility where they treat you as if you're the only patient there. I felt like that in Seattle, and I now know that I'll reach out to them for my next medical care. Well, hopefully never medical care. You got a lump that doesn't heal, seek out a dermatologist, get a biopsy, breathe, take a moment, enjoy your life, and reach out to the experienced medical staff wherever it may be. They have the research and the tools to identify and get you through this. But you also have to advocate for yourself. So if you think something is wrong, you know your body better, seek help, and don't let them tell you otherwise. Find out what it is. It may save your own life. And I am grateful to Dr. Niem's staff, the whole cancer community in Seattle, and hopefully this will help others that may be in the same boat as I was.
All right. It's time to talk about James Bond. And Samia Jani is going to come up, one of our wonderful MD PhD students, and give us some insights on what it takes to be the right kind of cancer cell and how, right kind of anti-cancer T cell, and how we're going to identify them. Samia?
Thanks, Paul, for the introduction. And as Paul said, I'm going to tell you about tumor-specific T cells. And I don't actually have a lot of James Bond knowledge, so ask me questions about T cells, maybe not James Bond movies. So killer T cells, as their name suggests, are the immune cells that directly kill tumor. And just to give you a better picture of how this happens inside the body, I'm going to show you a little video. So in this video, we'll see a killer T cell in pink interact with a large cancer cell in blue. So we see them interact, and we know that the killer T cell has recognized this as cancer because it stays stuck to the cancer cell, and because it's getting these cellular grenades that it's going to use to kill the tumor cell ready at the intersection of the killer T cell and the cancer cell. So then we see it release the grenades into the cell, and then the killer cancer cell becomes red and small as it dies. Yeah, this is. So I'll play it again so folks can talk or watch without me interrupting. Right, so this is great, right? And we want this to happen when we have cancer, but we don't want it to happen to our normal cells. We don't want our immune system to just attack things that should be there. And much like James Bond receives his mission, the villains to go after, all killer T cells also receive a specific mission or a specific target to kill. This killer T cell, for example, has received the mission of killing MCC. And the instructions it is given to be able to find MCC are written in something called the T cell receptor. And I'm going to use this schematic to represent that. Again, much like James Bond needs to travel to do his job, so do our T cells. They go to different parts of the body through our blood and use their T cell receptor to check cells along the way to see, is this Merkel? Is this not Merkel? If it's not Merkel, they move on. If it is Merkel, they stay attached to the T cell or to the cancer cell. But figuring out which T cells have received the mission of killing Merkel is difficult. And to address this, we focused on virus positive cases because we know what the Merkel virus looks like. And so we know what the tumor cells are fighting and what they're looking for. So here we see a T cell or or James Bond interacting with a cancer cell or the villain, and the T cell receptor binds to a little bit of the cancer cell and recognizes it as cancer. So we basically did the same thing, recreated this in the lab by taking the little bit of the tumor cell that the T cell recognizes and attaching a bright fluorescent tag to it. So we can now take this specific tag and put it in blood samples or tumor biopsy samples that we've received from patients and count how many T cells bind to it. And the T cells that bind to this special marker or the fluorescent tag, we know that they're going to recognize Merkel, and those are the ones that are fighting Merkel. So specifically, we did this for patients enrolled in 2 clinical trials, those for Opdivo and Keytruda. And we split up the patients based on whether they had these tumor-fighting T cells in their blood or not. And we asked how many patients remain cancer-free 4 years after they received immunotherapy. And the results are quite striking. The patients who had these tumor-fighting T cells in their blood, 75%, a majority of them did not have their cancer come back 4 years after treatment. But in contrast, a very few percentage of patients who did not have these T cells in their blood remained cancer-free. And this makes sense, right? If you don't have the right killer T cells, you're not going to kill the tumor cells. And while this conclusion is simple, the work that it went into finding this took a lot of time and effort. So just to give you an idea of that, the work showing that immunotherapy could be used for Merkel started in 2011. Clinical trials of immunotherapy in Merkel started in 2014, 2015, and these results are just now becoming available. So in total, it involved over 100 people working on this, over 11 years of effort, and over $1 million. And this took so long because decoding the mission that each T cell has received is really challenging. But we think that this will be easier in the future. Just as an additional note, we could only do this in virus-positive Merkel because we knew what to look for. But in other types of cancer, including virus-negative Merkel, we don't know what to look for because each tumor is caused by a different problem, and it's really hard to pinpoint each individual tumor's problems. So now that we have this information, what do we do next? How are we going to bring this to patients? How are we going to expand it to virus-negative Merkel and other cancers? So it's not currently routinely possible to do this in clinic, but we want it to be, and this is what my PhD project focuses on. I'm looking for fundamentally different ways of finding these tumor-fighting T cells such that we can easily count how many of these killer T cells a patient has in about a week. About the amount of time it would take for a patient to get a biopsy, be diagnosed with Merkel, and start treatment. And we also want to do this much more cheaply, around $500 to $1,000 per test instead of the large amount it took to find this result. And we have seen technology do this time and time again, right? There are so many things that are easier, cheaper now than they were in the past. And we think that this can happen for this specific problem as well. And I also want to do this in a way that does not require us to know what the problem for each tumor is, so that we can find these T cells without doing a lot of extra legwork to find the problem. And I won't go into a lot of detail about my specific project now, but one of the ways that we're trying to find these tumor-fighting T cells is by comparing how the T cells that can kill Merkel look compared to all the T cells that cannot fight Merkel. So just like we look different when we're really, really busy versus when we're on vacation, we think that T cells that are actively fighting cancer are also going to look different than T cells that are not fighting cancer and are just hanging out until whatever they are going to fight comes around. And if we can find patterns that mark tumor-specific T cells using the specific tags that we've developed in virus-positive Merkel, these patterns may also allow us to find tumor-fighting T cells in all other cancers. So what? What does this mean for patients? Why have I been telling you about this for the past 8 minutes? Well, if we can use these patterns to more easily find the tumor-fighting T cells in patients, we can give immunotherapy to those who already have the T cells, because as we saw, patients who have these T cells tend to respond well to the treatment. But for patients who lack these T cells, we need to do something else for them. For example, we can make these cells in the lab and give them to the patients before they get immunotherapy, so that now their chances of responding to the treatment are much higher than they would have been. So to conclude, we have recently learned that cancer-fighting T cells are good for responding to immunotherapy and that their number matters. However, it's not currently possible to measure how many cancer-fighting T cells a patient has in real time, but we are working on finding relatively cheaper and faster ways to find them. Thank you, and happy to take any questions. Yeah. Yeah. So the question was, how many patients who have the tumor-fighting T cells respond to immunotherapy? Is that right? Yeah. So we've seen that 75% of them, or a large majority, who have these tumor-fighting T cells tend to respond very well to immunotherapy and remain cancer-free over a long period of time.
And the number is about 0 for not.
Yes. And for patients who don't have them, that number is like very close to 0. Yeah. Oh, sorry, go ahead.
The video shows that. How long does it actually take that?
Ooh, good question. I think that whole video would take a couple hours. Yes, I hear there's questions from Zoom. Yeah, so one of the questions from Zoom was will T cells help patients who have virus negative Merkel? And the answer is yes, T cells will also kill their cancer cells, but we just don't know how to find the specific tumor fighting T cells because we can't use Merkel virus specific tools to find them.
All right. And Austin and Ariel, please come forward. So Austin Jabbour and Ariel Finberg are 2 wonderful clinical research fellows, and they're going to give you a quick tour of what's going on with the clinical trials. Austin's going to start with a few that we've got locally here. Austin?
Hey, everyone. My name is Austin Jabbour. Next to me is Ariel Finberg. Thanks for the introduction, Dr. Niem. We're both some of the clinical fellows in the lab.
Go ahead, keep going.
Oh, you're giving me my pointer?
Yeah,
Thanks.
reactivating the laser.
So we're going to move from Soumya's talk in the lab to kind of transition to what's going to be happening in clinics coming forward. So I'll start by talking about what recently just closed and what's currently happening, and then Ariel's going to discuss what's on the horizon for us. So the first trial I want to discuss is the vaccine trial that was alluded to early on during this discussion. This trial was developed about last year, and the idea behind it is that there's a virus that causes these Merkel cell carcinomas in about 80% of patients in the United States. Much like COVID-19, we developed a vaccine against that virus. We too were hoping that we could possibly develop a vaccine to prevent recurrences of Merkel cell in patients with who are positive for the Merkel cell virus. So I'd like to point your attention towards the pointer here. And I'm going to go through this graph on the top left for a minute. So shortly after we're first diagnosed with a primary Merkel cell carcinoma, and right around the time of surgery and sometimes radiation, we actually have a pretty good immune response that's working to fight back against that cancer. However, as time passes on after the primary surgery and radiation, we find that our immunity kind of starts to shrink as this line goes down the curve here. And that brings us to about a 6 to 9 month mark after the initial treatment, where we actually see most of these Merkel cell carcinomas come back. That's usually the window that most actually recur. And as we talked about before, about 40% of them do recur. The idea of the vaccine is basically if we introduce it shortly after surgery and radiation, we can boost that immune system back up. And those killer T cells that Samir was talking about, we can actually stimulate them and make a prolonged response. And the idea behind that is hopefully we would have less recurrences in the future based on this vaccine. So we had 6 patients participate in this trial over the last year. We're very thankful for their participation. Early data shows there was no significant side effects associated with the vaccine. And we're going to continue monitoring their T cells in the blood to see if we have actually achieved that sustained immune response. And then I want to thank the clinical team, Dr. Neum, Dr. Bhatia, and Dr. Park for conducting this, and then Dr. Cole in the lab. So what about after vaccines? And that is immunotherapy, which a lot of you know about. We talked about it a couple times during this presentation. These are 2 trials I'd like to highlight that are currently ongoing or recently completed enrollment, using immunotherapy to prevent recurrence of Merkel cell carcinoma. We know that these 2 drugs are already approved for advanced stage disease and disease that has spread to other parts of the body, but can we use this to actually prevent recurrences from happening? So on the left side of the stage here is the ATOM trial. That uses the immunotherapy agent Bavencio. And this was used in stage 3 disease only, or Merkel cell that has spread to the lymph nodes. And the participants were separated into 2 trials, or 2 groups, about half to receive the actual Bavencio agent and the other half to receive a placebo. And these administrations of medications would happen for 2 years. And then the plan is to monitor the 2 groups over time. Enrollment in this trial is almost complete. We're looking, from my last count, for about 6 more patients to be enrolled in the trial before we conclude enrollment. On the right side here is the STAMP trial. This trial uses the immunotherapy agent Keytruda, works in a similar fashion to Bavencio of turning on the immune system. But this trial was open to a larger range of disease in Merkel cell, stages 1 through 3. So that's localized to the skin all the way up to spreading to the lymph nodes. Similar to the ATOM trial, these were separated into 2 groups, either to receive the Keytruda or be placed on observation, basically. And this was to be administered over a 1-year period. This was a multi-center study across the country, and 280 patients have been successfully enrolled in the trial at this time. We'd like to thank Dr. Bhatia for leading the ATOM trial here, and Wenyi Chen for also being the trial protocol manager here. So we know about immunotherapy, but what's kind of active now beyond immunotherapy by itself? I'm going to highlight 2 trials here. The first one is the ATTACK MCC trial, which is currently active. So this actually relates back to Saumya's idea of T cells fighting the cancer. So what the idea is that we can reprogram these T cells to actually attack the Merkel cell tumor, and then we can actually infuse these back into patients along with giving them their standard immunotherapy. And we hope that boosted immune system and the extra T cells can actually, work to fight the cancer better. So this is only located here in Seattle right now. It's headed by Dr. Josh Veach, and we thank him for his efforts. And just to note, only patients who are virus positive can be recruited to this trial at this time. The other trial I want to highlight is the CARTOS trial, which is also active. This is taking place around the country as well. This uses an oral medication, actually, a pill, to actually turn on a protein in our body, in everybody's body. But this turns back on a protein to fight cancer in the body. So this trial is separating patients into 2 groups, either to receive the pill with Bavencio or just the pill by itself. And they're going to compare the 2 groups and outcomes from that. This is also indicated for most virus-positive Merkel cell patients, and it's located in many states on the East Coast, Midwest, and Texas. And we thank Dr. Michael Wong for being the lead investigator on this trial. I'll turn it over now to Dr. Finberg to discuss what's on the horizon.
Hello, everyone. I'm Ariel. I'm one of the other clinical fellows working with Austin under Dr. Neum. I'm excited to share the coming attractions, so to speak. First and foremost is our Matrix trial that'll be coming at the end of the year. And this is looking at treating Merkel cell through a totally different mechanism. So this is for patients where immunotherapy doesn't work as well as we want it to. It would be a pill, and it'll be given with or without Bavencio, and planning to open up around the country. Just to give a little bit of context, when immunotherapy doesn't work, it's because Merkel has a way of becoming almost invisible to the immune system. It's this cold tumor. And so the way that this medication would work is it not only kills some of the cancer cells, but more importantly is it seems to bring the immune system to it. And so it kind of makes it visible, so to speak. So not only theoretically are we able to treat the cancer then and there, but ideally keep it away. This has been shown to work well in mice, and so this would be the first trial to be shown in humans. The next trial we have is the TRICK MCC trial that'll also be opening up at the end of the year. That's looking at using triple agent immunotherapy, targeting 3 of these breaks, so to speak, on the immune system. Again, to give some therapy, as Dr. Neum had alluded to earlier, prior to 2017, when we used traditional chemotherapy, really only about 5% of patients had a significant long-term effect. And around this time, we learned of this molecule, PD-1, which served almost as a brake on the immune system, and it didn't let it activate it as well as we wanted to. And so a medication was able to be designed to be able to block that, sort of cut that brake line. And we saw, again, a 10-fold increase from 5 to 50% of patients doing significantly better. However, with that, the other 50% still didn't respond as well as we'd wanted to. And in that time, we've learned that there are other brakes that exist on the immune system, like LAG3 and TIM3. And we've been able to design medications to block those. And so hopefully that this leads to not only a better response in the short term, but also the long term. Austin and I have highlighted a handful of trials that we are quite involved in here at Fred Hutch and the University of Washington. And here's just a map of the US and Canada that shows some of the locations of where they are. But more importantly to note, just as last week, there are 50 current recruiting or active studies that include Merkel cell patients that are happening all over the country. An example of one of these is out of New York. This is looking at a radiation and really targeting radiation to just the cancer cell. So traditionally, radiation is given with the machine. It treats an area. The cancer and also the normal tissue around it is affected. This would be an infusion, however, and theoretically deliver radiation only to the cells that have a certain receptor, which conveniently seems to be on Merkel and not on many other normal cells. Some other immune-based trials, the Checkmate trial, you may have heard of the TVEC. These are trials that involve both injections and infusions. Checkmate is looking to boost both the non-specific and specific immune response, and it's happening all around the country. And the TVEC trial is actually injecting a virus into the tumors to, again, help it not hide as well as giving infusions. If you want to read more about current clinical trials that are happening, as this information is updated almost daily. These are 2 of the websites, both clinicaltrials.gov and ResearchMatch. Clinicaltrials.gov is a little less user-friendly, but that's what Austin and I are here for. And we're really here to kind of help partner and be that middleman between some of the specialists and you, and here to answer any questions that you may have. And so with that, I understand that we are, I'm happy to take a question from the Zoom chat, and then Austin and I are around all of tonight to answer any questions you may have. The question was, how many of these questions extend worldwide? How many of these trials? Sorry. To be honest, I don't have that number in front of me. It's 50 just in the US, but I can find that number and get back to y'all quite quickly. All right, with that, I'm happy to introduce, oh, yes.
Yes, sir.
Yeah. Yeah. The question was, what is the main difference between immunotherapy and chemotherapy? And as I think I like to think about it, is an immunotherapy is a drug that works directly on the immune system and kind of starts to rev it up, whereas a chemotherapy really attacks in a less specific way. It really kind of attacks cells that are dividing quickly, or attacks like DNA replication, but it's not as specific as working on the immune system. It attacks cells that like divide quickly. So like a lot of people lose their hair when they're on chemotherapy, and this is one of the cells that divide quickly. Okay, and with that, I'd like to introduce our last patient story, Mr. Paulson.
Hi, my name is Rich, and I live in Reston, Virginia. I'm 67 years old, and I was diagnosed with MCC in February of 21. I received a kidney transplant 26 years ago and was told that the immunosuppressant medications required to prevent rejection will likely cause me to get skin cancer over the long run. About 3 years ago, I got a rash on my chest and it wouldn't go away. So my dermatologist did a biopsy that showed a collision of both squamous cell and something called Merkel cell carcinoma. And I hadn't heard of that. So I Googled it, and wow, it's like I felt like my life just kind of came crashing down. I always get multiple opinions for stuff like this. So I met with Dr. Evan Lipson at Johns Hopkins in Baltimore and Dr. Neem in Seattle. Well, not even 4 months after my initial treatments, I noticed a small like BB under my skin. So my team recommended immunotherapy, but I was a little reticent about that because I understood that it normally causes the kidney allografts to fail. So I met with my nephrologist, and he recommended doing the immunotherapy, but also monitoring kidney function using a cfDNA test. The logic was that the immunotherapy, if it started to induce kidney failure, could be caught early enough before it became irreversible. So I started a standard course of pembrolizumab of 200 milligrams every 3 weeks. Unfortunately, my tumors kept growing out of control. And at one point, I had over 50 tumors on my chest, many the size of marbles. The consensus of my team was that the immunosuppressant drugs were affecting the efficacy of the immunotherapy. And so they recommended that I just stop those drugs completely, but that would mean going back on dialysis. Meeting with my nephrologist again, he proposed that we reduce the meds to the lowest level possible. So that's what I did. Then by my 4th infusion, the tumors stopped growing. They regressed, and then over a course of another 3 months or so, they disappeared completely. Anyway, I've been NED for 18 months now. My kidney transplant is doing better than it ever has. And I know I'm not out of the woods yet, but I'm certainly in a great place and a very happy camper at this point. So I hope that things will continue that way. If I were asked to give advice to people who have just been diagnosed with MCC, I would offer a few things. First of all, you need to have experts on your team. If you go to the merkelcell.org site, you'll find a list of qualified oncologists there. So if yours isn't on the list, then pick one that is. Second, you need people around you that can really give you support during this time, because unless you're a Vulcan like Spock, you're going to have some rough days. But also take a look at another website for patients where you'll get to hear what they're going through. It's run by another MCC survivor named George, and you can find a link for that on the merkelcell.org site. And lastly, carpe diem. When I was first diagnosed with MCC, I really felt like I was letting my family down. I felt very guilty. Our son's birth mother had died when they were young. We had big plans for retirement, so we made plans. We updated our wills. I mansplained how to deal with the smart home system that we had to my wife. And, I just started tackling the items on my bucket list, and that was a lot of fun. I stopped worrying about dying and focused instead on living and beating the cancer. And doing all these things was really therapeutic. Finally, I want to express my utmost gratitude and admiration of my medical team. There is something truly special about those of you who are devoting your life to curing cancer. So to all of you, I say bravo, bravo. And thank you so much for listening to my story.
So we're at additional questions. We're a few minutes after 6. Folks wearing red lanyards will be happy to answer questions. And we just want to thank you all very much for coming and for the diverse things that you have contributed. And it's time now for you guys can go out and fire up on food and dessert and beverages and things. And then we'll take a team photo. So if everybody can come down here quickly, we'll get our 2023 Team Merkel group photo. Thank you all for coming so much. Thank you.